So next presentation is by Dr. DIVYA GIRIDHAR, Indication and Outcomes of Kpro swap in MOOKP.
Good morning, respected faculty. I'll be presenting on indications and outcomes of Kpro swap in modified osteoodontokeratoprosthesis. I have no financial disclosure. Kpro removal or extrusion is one of the devastating complications of Kpro surgery. This would invariably require a re-Kpro in these eyes, either replacing using the same Kpro or another Kpro suitable for the indication, collectively termed as Kpro swap. For MOOKP, the options of Kpro swap include a re-MOOKP, a Boston type 2 through the mucosa and its versions, or an osteo-Kpro. The choice of Kpro depends on the availability of another tooth, ocular status, that is presence of active leak or melt, and possible estimated visual potential. The aim was to analyze and report the functional and anatomical outcome of Kpro swap in eyes in which primary MOOKP had to be removed or had extruded at a tertiary eye care center over 19 years. The anatomical success was defined as the retained Kpro, and the functional success, a BCVA achieved better than 20/400. A total of 117 eyes of 112 patients underwent MOOKP, out of which 27 eyes required a second Kpro and 7 eyes required a third Kpro. Among the indications, the most common indication for second and third Kpro was Stevens-Johnson syndrome followed by chemical injury. On the left side is a case of a Boston type 2 Kpro which was done following cylinder extrusion in a primary MOOKP, and on the right hand side is a Boston type 2 Kpro following laminar resorption in an MOOKP. This is a case of a Lucia type 2 which was done following laminar resorption of a second Kpro which was again done following laminar resorption of a primary MOOKP. A total of 27 eyes underwent a second Kpro, which included 12 re-MOOKPs, 7 Boston type 2, 6 Lucia type 2, and 1 each of Lux Kpro and Osteo Kpro. Out of these, 14 eyes retained the second Kpro, which were 2 re-MOOKPs, 7 Boston type 2, 4 Lucia type 2, and 1 Lux Kpro, and these Kpros were retained till the last follow-up. Out of the 13 eyes which did not retain the second Kpro, 7 eyes underwent a third Kpro, which were 5 Boston type 2 and 2 Lucia type 2, out of which 6 eyes retained the third Kpro until the last follow-up. The pre-op visual acuity was perception of light. Among the second Kpro, a BCVA of more than 20/400 was achieved in 81.48% eyes, and among the third Kpro, the BCVA of more than 20/400 was achieved in 100% of eyes. This is the Kaplan-Meier survival curve for anatomical and functional survival of the second Kpro. The graph on the left side is the anatomical survival, which is 88% at 1 year and 33% at 5 years. And on the right side is the functional survival curve, which is 84% at 1 year and 42% at 5 years. Out of the 14 eyes that retained the second Kpro, a BCVA of more than 20/400 was achieved in 78.5% of eyes, and among the 6 eyes which retained the third Kpro, a BCVA of more than 20/400 was achieved in 100% eyes. Among the complications, the retroprosthetic membrane was most commonly seen in a Boston type 2 and Lucia type 2, and a mucosa-related complication was most commonly seen in a re-MOOKP. Out of the 20 eyes which retained the re-Kpro, a BCVA of more than 20/400 was achieved in 17 eyes, out of which 6 eyes maintained the vision till the last follow-up. And among the remaining 14 eyes, 12 eyes maintained self-ambulatory vision till the last follow-up. Thus, a re-Kpro overall helped improve the functional outcome for 31.62 months and improve the anatomical outcome for 39 months. Laminar resorption leading to Kpro instability remains a vision-threatening complication, and attempts should be made to preserve anatomical integrity for simultaneous or future visual rehabilitation. Kpro swap is a term that includes Kpro of the same type or exchange with another type of Kpro for the above situation. Decision making for Kpro again depends on the availability of another suitable tooth and estimated visual potential. If the visual potential is good and there is available suitable tooth, a re-MOOKP is an option, whereas if the visual potential is questionable and lack of suitable tooth, simultaneous removal of MOOKP and implantation of a type 2 Boston or its other versions through the mucosa is an option. In our series, 74% of eyes that underwent a Kpro swap retained subsequent Kpros. Though only 22% maintained a BCVA of more than 20/400 at last follow-up, another 44% retained self-ambulatory vision. A concept of Kpro post MOOKP is rarely discussed in literature. Early stages of laminar resorption can be addressed using bone morphogenic protein. However, later stages require a Kpro swab as discussed and helps to increase the duration of visual rehabilitation by a mean period of 3 years and beyond. This is facilitated by a comprehensive training in all kinds of Kpro surgery that helps enhance outcomes following MOOKP in eyes requiring laminar removal. To conclude, Kpro swab in MOOKP eyes with laminar resorption is a viable option to increase the structural and functional outcomes with the choice of Kpro for the resurgery tailored to individual situations. These are my references. Thank you.
Presentation, Dr. Divya. What was the interval between the swab pits, one surgery and repeat surgeries?
Ma'am, so that depends actually on the indication for the surgery. So if it's a patient who had like a Kpro melt or a leak, then if the patient required an immediate surgery, and so then we would remove the Kpro at the primary sitting and rehabilitate the patient immediately. But if it was a patient who we had time to probably harvest another tooth and plan a re-MOOKP, then there would be a time gap between the primary surgery. We would first remove the lamina, tectonically stable the eye by doing a tectonic PK, and then do the surgery after the eye is stable. So it depends on the indication of the reason why we're removing the lamina.
What was the age group of your patient?
So it was between 18 to 56 years, sir, on an average.
Okay, thank you so much.